We speak in terms of risk factors for macular degeneration because we still lack a full understanding of this disease. The first set of risk factors are those that we cannot control. Age. Macular degeneration rarely occurs before the age of 50 and is more commonly seen beginning in the 7th decade of life or later. Race. Macular degeneration occurs more frequently in Caucasians. Less pigmentation of the skin also means less pigmentation in the protective RPE layer beneath the photoreceptors. Blue eyes. Less pigmentation of the iris may also mean less pigmentation of the RPE layer. Gender. Studies vary, but even when correcting for the longer lifespan, women may have a higher incidence of macular degeneration. Family. Family members of macular degeneration patients are at higher risk of developing this disease. Multiple researchers have each separately confirmed that an abnormality in the complement factor H gene appears to be associated with a significant increased risk for developing macular degeneration. The variant of this gene appears to allow for an increase in inflammation in the retina. This may be consistent with our knowledge that the drusen's we see at the start of macular degeneration do contain some molecules associated with the inflammatory process. The second set of risk factors are those that we can modify. These make up what we call the puzzle of prevention because patients and family members desperately want to know what to do, but often find confusing information. The first piece of the puzzle is smoking. Here the evidence is very strong. Smokers are 2 to 5 times more likely to develop macular degeneration than non-smokers. Studies show that smokers may acquire macular degeneration as much as 10 years earlier than non-smokers. Smoking may be associated with more severe forms of macular degeneration, particularly the wet form of the disease. The AIRED study was a national multi-center study funded by the National Eye Institute. It followed over 3,600 macular degeneration patients. The results showed about a 25% reduction in the risk for progression of intermediate macular degeneration to the advanced form of the disease. AIRED vitamins include high doses of vitamin C, E, beta-carotene, which is a form of vitamin A, zinc, and copper. Current or recent smokers should avoid high doses of beta-carotene, as 2 studies have shown a 20% increase in the risk of lung cancer. Researchers at Harvard have found that obesity increases the risk for macular degeneration. This may be due to an increase in inflammation. Discuss your body mass index with your doctor. Your physician can determine whether diet and exercise are safe for you. Several studies suggest that chronic elevated blood pressure may be an additional risk factor. Be sure to work closely with your physician to control your blood pressure. All of the facts are not in yet on cholesterol and macular degeneration. However, animal studies in mice have found that lipids may accumulate in Bruch's membrane, which is the layer between the RPE and the vascular-rich choroidal layer. One study of older Americans taking statin drugs, which are medicines used to treat high cholesterol, found they were half as likely to go on to develop macular degeneration. Work with your physician to detect and manage elevated cholesterol. An active lifestyle may reduce the risk of developing macular degeneration. It appears that macular degeneration and cardiovascular disease may share common risk factors. One study found that participating in physical activities 3 times a week reduced the risk of macular degeneration. Before making major changes in your physical activities, talk with your physician. Lutein and zeaxanthin are retinal carotenoids. They are fat-soluble yellowish pigments found in many green leafy vegetables such as kale and spinach. In 1985, Bone and Landrum found that the protective pigment layer above the macula lutea, was composed of lutein and zeaxanthin. There is growing evidence that eyes that have thinner layers of these pigments have a higher incidence of macular degeneration. As light-gathering pigments, they seem to play a protective role in plants, and now there is growing evidence that they play a role in protecting the human macula from excessive high-energy blue and violet light. Food sources of lutein and zeaxanthin include many green leafy vegetables and egg yolks. Lutein and zeaxanthin supplements are also available. The National Institute of Health has not yet established minimum daily requirements of these two supplements. Not all green vegetables are high in lutein or zeaxanthin. You would need to eat 15 cups of green beans to get the same amount of lutein in a half a cup of kale. This list will help you find vegetables with higher contents of lutein. Macular degeneration patients should add 5 to 7 helpings per week of vegetables high in lutein and zeaxanthin. If you are unable to eat enough vegetables, consider a lutein supplement of at least 6 to 10 milligrams per day. If you are on a blood thinner like Coumadin or Warfarin, you should not eat high amounts of green vegetables which contain vitamin K. Discuss any dietary changes with your physician. While not all studies have been in agreement, there is growing evidence that blue light may be harmful to the macula. As we have learned in this program, white light contains all colors of light. Each of these light refracts differently from a prism due to their wavelength and energy. When we see a rainbow, we see the light we live in divided into its component colors. The blue and violet light in a rainbow has 15 times more energy than the red light. Amber brown lenses can help reduce the blue light reaching your retina. Omega-3 fatty acids are long-chain fatty acids found in fish, nuts, and flaxseed oils. There is strong evidence that increasing omega-3 fatty acids in our diet has beneficial cardiovascular effects. There is also now growing evidence that increasing omega-3 fatty acids and reducing omega-6 fatty acids may be beneficial in reducing the risk of macular degeneration. American diets are heavy in omega-6 fatty acids, those that come from beef and chicken. Researchers at Harvard University have found that subjects that had eaten the proper balance of omega-3 and omega-6 fatty acids had less macular degeneration. The recommended ratio of omega-6 to omega-3 should be about 3 to 1. Unfortunately, American diets typically have a ratio of omega-6 to omega-3 fatty acids of 15 to 1 or greater. These diets are lacking in omega-3 fatty acids while having an excess of omega-6 fatty acids compared to the diets from which our ancestors evolved. There is growing concern about the type and quality of cooking oils. Hydrogenated vegetable oils are chemically altered and thus may be difficult for our bodies to process. Polyunsaturated oils contain high amounts of omega-6 fatty acids, tolerate heat poorly, and may accumulate in tissue. You should cook with high-quality monounsaturated oils such as canola oil or extra virgin olive oil. They tolerate heat better and have good omega-6 to 3 ratios of 2 to 1. There are still missing pieces to this puzzle. With advancements in macular degeneration research, we are learning more about this disease and are hopeful for new and better treatments and the possibility of a cure in the future.